So this session entitled On the Diabetic Foot, and this we'll be talking about evidence base for what we do. I'll take my mask off so you can hear me. So, in American, I'm sure you all know what the PITS means. If it's the PITS, it ain't too good. And sadly, in the past, diabetic foot management has not been too good. But we can use these 4 letters to talk about what we should be doing. Prevention, by identifying those at risk, treating them, and providing a service to screen and to look after people with diabetic foot problems. So, we know from prospective observational studies performed by ourselves and others that people in the risk categories listed here are indeed at greater risk of developing a foot ulcer. Those with neuropathy, both somatic, loss of the gift of pain, first described in leprosy in India, and autonomic, peripheral sympathetic dysfunction leading to reduced sweating in the feet. Peripheral vascular disease, clearly a risk factor, and those with a past history of foot ulcers. The recurrence rates are horrific. In good centers, recurrence rate, if you've had a foot ulcer, is 30 to 50% per year. Those with other microvascular complications, especially, and I can't emphasize this enough, especially those with end-stage renal disease due to diabetic nephropathy, the most at-risk patients of all are those who are on dialysis, who always have the other complications, including neuropathy and usually peripheral vascular disease. And most important amongst the others, if you've got a history of amputation of a toe or part of a foot or a leg, then the other foot is, of course, at risk. Now, it was Dr. Paul Brand working in Vellore in Tamil Nadu in India as a missionary surgeon looking after people with leprosy who said this: you do not need expensive equipment to diagnose the high-risk foot in diabetes or leprosy. And I said to you already from Corrigan in my last talk, the trouble with most doctors is not that they don't know enough, but they don't see enough. They look, but they don't see. And this is the high-risk foot I showed you. All the risk factors are seen in this one foot. For many years in Sheffield and later Manchester, we've done a lot of studies looking at the relationship between pressures and loads under the diabetic foot and ulceration. And this slide summarizes 10 years of work. High foot pressures are associated with first and recurrent plantar neuropathic ulcers. Foot pressure abnormalities occur early and can be found before there's clinical evidence of neuropathy. We showed in this longitudinal study that high foot pressures predict plantar ulcers in the neuropathic foot, and we also showed that plantar callus is associated with high pressure and predicts foot ulceration, and removal of callus in debridement or debridement reduces foot pressures. Nothing is new in medicine, it's rediscovered. And this is Dr. Paul Brand. Working in India nearly 60 years ago, this was done. And he said that pressure is the critical quantity that determines the harm done by the force. And here's Dr. Brand, and this paper was published in the Journal of Bone and Joint Surgery in 1963. And this were very early pressure measurements using pressure transducers attached under the high pressure points, the metatarsal head, toe, and heel. But today, of course, we had much more sophisticated equipment to identify pressures and loads under the diabetic foot. And this is one of them here. And this is like the mountain peaks. The higher the peak, the higher the pressure. And this is a very high pressure at the site of this typically neuropathic ulcer. The morphology tells you that this is neuropathic. The position, the high pressure, the buildup of callus due to repetitive pressure and the lack of sweating. More recently, we've been interested working with our friends and colleagues at Manchester Metropolitan University, particularly Professor Neil Reeves, looking at novel pressure sensing devices and smart insoles to reduce foot ulcer incidence in high-risk diabetic patients. And this was a randomized trial published in Lancet Digital Health 18 months ago. And in this paper, the background I've already told you. We know that high pressures are associated with first and recurrent ulcers. But normally pressure has been a laboratory measurement, but now we have the concept, first developed by Pateki and et al. Actually in Switzerland, the concept of pressure feedback. Can the patient be informed of the high pressure? Therefore, the aim of this study was to investigate efficacy of pressure sensing smart insoles for reducing foot ulcers in high-risk patients. So this was a randomized single-blind controlled trial. The patients were given good footwear, and inside was inserted this pressure sensing smart insole. And this fed back wirelessly to a wristwatch that the patient wore. There it is. It didn't tell you the time. It really told you if there was a high pressure. And if you had recurrent high pressures during walking, there would be vibration, the wristwatch would vibrate, and it would highlight the area where the pressure is too high. So the patient was either advised to alter the gait, and you can follow where the high pressure is, to alter the way they were walking, to reduce the pressure there, or to stop walking and rest. Well, this simple intervention reduced foot ulcer recurrence by 70%. 86% reduction and time to ulceration in those who were judged to be most adherent and were wearing these at all times on many footsteps. The overall study ulcer rate was actually quite low, and this is not altogether surprising because patients, knowing they're in a study, tend to be more likely to adhere to the advice we give them. The mechanism of working is by reducing recurrent pressures. The high pressure plus loss of feeling leads to breakdown and, of course, empowering the patient. Now, that one thing we can measure is pressure, but another thing is heat. And I come back again to India. Studies done in the 1960s and 70s, and again Paul Brand with Bergholt reported that infrared thermography contributes to the care of the insensate limb. It can detect through heat areas of irritated skin prior to breakdown, and therefore can effectively manage, can prevent permanent injury. So the foot warms up before it breaks down, is what Brand showed. So this was Brand's paper. A very early thermography. You see there's very high temperature here, and this area is undoubtedly pre-ulcerative. It's likely to break down. And what he showed was that the foot, before it breaks down, warms up due to local inflammation. This is probably a patient who's been lying on an orthopedic board for ages and nobody's bothered to turn the patient. They have lost the gift of proprioception, of pain, of pressure, therefore they just lie with their foot in one position. So the next question moving forward is, can we prevent ulcers before they actually develop in the pre-ulcerative stage? So we know that nerve damage, mechanical stress leads to inflammation, the foot warms up, then it breaks down, ulceration. So is it possible to stop at this stage? Well, some good friends of mine in Texas, Larry Lavery and colleagues, did an NIH-sponsored trial that was published some years ago, in 2007, if I remember. Yes, correct. And this is the study. And he took 3 groups of patients. These were all mainly Mexican Americans with type 2 diabetes, dense peripheral neuropathy with a history of plantar foot ulcers. And they were randomized to one of 3 groups. The first group was, and it was pretty good care, they were given special shoes, they saw a podiatrist every 2 months, and were given a leaflet on how to look after your feet. The second group got that, plus they were given a mirror. And because if you've been to Texas, a lot of people are rather large and they can't see their own feet. So the mirror was on a long stick so the patient could inspect their feet on a regular basis. And they were very generous. They gave them a notebook, like one of the notepads you can take here, and the patient was asked to make records if they found an abnormality and contact their podiatrist. The third group got all this, plus they were given a temperature device. So the patient was given a dermal thermometer. They could measure the foot temperatures, and they had to check them twice a day. If one foot was persistently more than 5 degrees Fahrenheit to 2 degrees Celsius warmer than the other, they were advised to stop walking and contact the podiatrist. the results were quite remarkable. Look at the recurrence ulcers rate. In the standard group with education, the structural group with a mirror and a book, 1 in 3, just under a third of patients got recurrent ulcers. But those who were temperature monitoring and stopped walking and rested had a recurrence rate that was reduced to 8%. Highly significant. And 2 other studies have shown similar results. So this can be used. And here's the result. Recurrence rate 8% here and equal in the other 2 groups. So self-temperature monitoring is a potential way for patients to monitor their feet. Something more than education, they have an intervention too. And then it can act on that if the temperature is consistently high in one foot compared to the other. This has been taken further, and this study by our friend and colleague Bob Freiberg, published a few years ago, smart technology to predict fault ulcers. And this was using like a bath mat you can stand on, but this fed by Bluetooth to a central monitor that told you the temperature of both feet. Now this was at the beginning, so it was just an observational study. So he took 132 high-risk patients, followed for 34 weeks, 9 months. They did daily foot temperature assessed remotely through the mat, and plantar temperature asymmetries were watched and then analyzed. Now, of this group, they were very high risk. Just over a quarter, nearly 29%, had recurrent foot ulcers. 97% of these ulcers could be predicted correctly by an asymmetry of more than 2 degrees Celsius between the ulcerating foot and the non-ulcerating foot. So prediction and prevention should be possible, and now there is a randomized trial going on where one group is having this fed back to them and the other group is not. So times are changing. Patient technology. The old is where we see someone in the clinic, we examine them, give them tablets, whatever. The new is using smart technology, remote monitoring, and so on. So the solution could be continuous foot monitoring systems for diabetic patients and a real-time sensor-enabled wireless device for the diabetic foot. Can be monitoring any of several things. So smart technologies, I've shown you, can be temperature assessment or continuous pressure monitoring. See it, save it. Here's a patient, this is a pressure stat. The darker the area, the higher the pressure. This can be given to the patient. So seeing is believing. This is the temp stat that can be measured like a bathroom scales, but it gives you the temperature assessment that the patient can see immediately via an app. Now this is American humor, but success means success. This shows you that smart socks, this is Ran Ma and colleagues from a company that won the Consumer Electronics Show prize of $50,000 for developing smart socks. The patient can wear these socks and they can feed back the temperature and the pressure. As shown here, the smart socks can tell a temperature differential. So you teach me and I forget. You show me and I remember, you involve me and I understand. So we need to involve patients more in the next talk we'll deal with. What about treatment? The last 5 minutes or so I'll go through the fact that we do have now some evidence-based therapies for diabetic foot problems. We know that a diabetic foot ulcer should heal if the arterial inflow is okay, if you treat infection appropriately and aggressively, and you remove pressure from the wound and its margins. We're at least good at removing pressure, because doctors find it hard to believe that someone with a huge hole in their foot would walk on it. So there's been a renaissance in diabetic foot care. This is my friend and colleagues from King's College Hospital, Mike Edmonds, who's been working in the field, we've been working in the field for about exactly the same time. We've been good friends for 40 years. We're both still working. So this is recent guidelines on the design of randomized controlled trials. One paper by myself, Loretta Vilakite, William Jeffcoat, Ed Boyko, giving advice on how we should design trials, because trials have failed in the past because they haven't taken into account confounding variables, the most important of which is that the patient will walk on an ulcer. Drug companies have developed new treatments. They won't believe that someone will walk on the ulcer. So you can put $2,000 of artificial skin on a foot ulcer, But if you walk on it, you've killed it. So many companies have lost millions of dollars by poorly designed trials. But now we're having good design trials following guidelines by ourselves and the International Working Group. Here's the leucopatch system in a nice randomized trial. This is bent-side centrifugation without additional reagents to generate a disk of autologous lymphocytes, leukocytes rather, platelets and fibrin. Then you put this plug onto the wound. In this study, there was more rapid healing in those who were treated with leucopatch than control, taking account of offloading and all the other variables. Then there was this sucrose octasulfate dressing, the first proven treatment to help healing of neuroischemic ulcers. 240 subjects with neuroischemic ulcers were enrolled with more rapid healing in the sucrose octasulfate dressing versus the control. No safety problems. So here's an evidence-based therapy for neuroischemic ulcers. Now we're seeing benefit of topical oxygen. Hyperbaric oxygen has been used for years, but the evidence is terribly limited. It's very poor. And apart from the United States, virtually nobody uses hyperbaric oxygen to treat foot ulcers. Being a cynic, I tell the hyperbaric specialist that actually it is a very good way of offloading because you can't walk around inside the chamber, but it's a somewhat expensive way of offloading. But now there are various different topical oxygen devices. This is transwound oxygen here, and this I'll show you a randomized controlled trial that shows benefit. Here's a study again by Bob Freiberg, just published a year ago. Patients are randomized to topical wound oxygen or sham following for 12 weeks. And there was much more rapid healing in the transcutaneous oxygen group. 12 months, 56% remained healed. So not only do they heal, the healing is sustained. So there are more studies coming through on this, and there will be a symposium on this at the International Diabetes Federation Complications meeting. So topical oxygen looking promising. Lastly, what about infection? We still use clinical criteria to diagnose infection. Odor, not difficult. Pus, cellulitis, swelling. There's no doubt that this is a Charcot at the cuneiform metatarsal joint, that there's clearly an abscess here, and this is clearly infected with pus dripping out, and this is clinical definition of infection. But we must remember that antibiotics are not growth promoters. They're not wound healing agents. They're not household cleaners. They're not hand cleaners. They're not scalpels. Gross overuse of antibiotics has led to much antibiotic resistance. Osteomyelitis. Here's a randomized controlled trial from Luis Lazaro Martinez and colleagues in Spain. The randomized study showed that local surgery is no better than oral antibiotics in localized osteomyelitis. So we can get radiological healing with antibiotics alone. Here's a very important study published in the New England Journal a couple of years ago, the Aviva Trial. That stands for oral versus intravenous antibiotics, very simple. This is a randomized trial in osteomyelitis of over 1,000 patients in the UK. They were randomized to oral or intravenous antibiotics, and the outcome showed no benefit of intravenous over oral antibiotics. I very rarely use intravenous antibiotics for osteomyelitis. We use 6 to 8 weeks of oral antibiotics. So to conclude, although the incidence of foot ulcers continues to increase, there have been some advances in the last 5 years. Firstly, in infections, randomized controlled trials are at last guiding management, like the Aviva study. Therapies, now we're seeing well-designed randomized controlled trials providing evidence of efficacious therapies. Smart technology, there's a digital revolution going on, and perhaps the Internet of Medical Things will provide huge opportunities for the future of diabetic foot care. So here's a quotation from the Old Testament, the book of Ecclesiasticus. In chapter 18, verse 19, it says, "Before you speak, learn," that's a good idea. "But before you fall ill, take care of your health." And that's great advice for people with diabetes at all stages, particularly those with a history of foot ulcers, because they don't need to be recurrent. So again, I thank you for your attention and remind you about our Virtual Complications Congress coming up in 6 weeks' time. Shukran.
No, because they are two separate questions. I will ask you now. Thank you very much, Professor Boulton, for a wonderful presentation. If you allow me to ask you a question, you showed us very well how important it is to detect and screen the temperature levels of the food in order to predict the areas at risk of the development of diabetic foot ulcer. And my question is, how if the patient is ischemic, I mean he has an ischemic diabetic foot, how could ischemia influence the assessment of temperature? Because of course we all know that ischemic feet are a little bit colder than the non-ischemic one. How could ischemia influence this predictor? Yeah,
these were in primarily people with neuropathic or neuroischemic problems of a mild degree. Now, I'm not a great fan of the ankle brachial index in diabetes because of vascular calcification. You can get false reassurance. So these people had palpable foot pulses, or they had a triphasic or biphasic Doppler signals over the PT and DP arteries. So I think this will not be as effective, but even the neuroischemic foot still heats up before it breaks down, but to a lesser degree.
So the floor is open for discussion. Okay.
Thanks again, Dr. Boulton. Do you think about use of arterial or venous duplex for screening of ischemic diabetic foot ulcer can be used routinely screening for routinely?
You said it's a duplex. You said. What be used?
Arterial and venous duplex.
Oh yes, absolutely. I believe that a handheld Doppler is more helpful listening to the waveforms than measuring the ankle brachial index. It's quicker. I see many patients, most of our patients with high-risk feet have either vascular stiffness or frank calcification, medial calcification. So the ankle brachial index is falsely elevated. So you can have someone with significant vascular disease with still a normal ankle brachial index. So listening to the Doppler waveforms with a handheld Doppler device is what we do in the clinic. I listen to the DP, dorsalis pedis, and the posterior tibial arteries, and can get reassurance if you have a triphasic waveform. I think it's very useful to the trained ear, but you need to learn the different waveforms of monophasic, suggesting proximal obstruction, triphasic, or the machinery murmur of autonomic neuropathy with the release of vascular tone and a loud signal right the way through the cycle. No reversal of flow in autonomic neuropathy. So there's different kinds of waveforms. I teach all our junior doctors to listen and define which is which.
Another question? Okay. The role of alpha lipolic acid in management of neurovascular.
The question, please.
Neuropathic foot ulcers, I think alpha lipoic acid has no use. Alpha lipoic acid is better for people with early neuropathy, in advanced stages of neuropathy. Basically, even though Riaz and us in Manchester have shown you can get beginning of regrowth of small fibers in the cornea, it's unlikely you're going to have normal sensation, protective sensation return once you've got advanced neuropathy. So alpha lipoic acid is better for early intervention, not for late.
Do you think that duplex mapping as well, or duplex ultrasound, may be beneficial in cases where there is abnormal signal by Doppler to detect any occlusion, especially in the infrapopliteal region?
Absolutely, we use that regularly. We're guided to that by what we hear. And I much prefer that because I'm still rather cautious about doing too many arteriograms because most of these patients have renal dysfunction. And even some of the better contrast media, they're still a bit risky. So we only use those if we have to. So a duplex is very helpful.
Okay, thank you.
I think Mohammed is there waiting.
We have here also Dr. Mohammed Hassanin. I would like to ask you a question. Please, Dr. Mohammed.
Yeah, thank you very much, Andrew. We've been bombarding you with too many lectures for the conference. Couple of quick questions. Do you think that the IV antibiotics made no difference versus oral in people with primarily neuropathic problems, or was it with mixed or mostly vascular problems? Because the rate of smoking in the region here is pretty high, and many of the patients have a very much of a vascular component as well.
I would agree entirely. My clinical observation here is people are smoking outside the conference room, which is amazing. So yes, you're right. I think that in people who are smokers and vascular disease, we need to be much more careful. You're right. What was the question again with respect to what?
Do you think that the IV antibiotics did not make much difference because of the neuropathic problem?
The Aviva study was in osteomyelitis across the board, and only 20% had diabetes. But certainly, one needs to be more cautious with people with neuroischemic ulcers. And I'm not saying if I have someone with gross osteomyelitis and their fever and they're admitted to hospital, we'll always start with intravenous antibiotics. But I think the need for outpatient antibiotics, and it's terribly expensive. I see them coming to put these PICC lines in, and they've got a home visiting nurse every day. Even the line has an infection risk itself. And I think this is grossly expensive, and they came to my clinic, can we put an advert up for the IV screen, antibiotics? I said, no, you can't, because we rarely use them. But to begin with, I think most people deserve, if they're hospitalized with a fever, etc., we start with IV, then switch to oral. And during the pandemic, I wasn't even allowed to do a routine foot x-ray or a routine blood test. Now, all the junior doctors look at the CRP. I said, forget the CRP, we're treating the foot, not the CRP. So we managed very well with things like ciprofloxacin and clindamycin for 6 weeks, and when it was all over, we could do radiology. We could see it was radiological healing. And these were diagnosed by clinical science, sausage toe, probing to bone. We couldn't do an x-ray, couldn't do any blood tests, but these people got better on broad-spectrum oral antibiotics.
A quick other question, if I may, Andrew. During your lecture, you've highlighted the issue about the smart socks. Now, we have many firms who try to make us sort of endorse these socks. Is there, maybe you can elaborate a touch more on this?
I think we need to be very careful. These are in their early stages, and there are many people peddling socks. They help diabetic feet. And I think all these need careful assessment. A sock can do as much harm as an ill-fitting shoe. And we did some studies years ago where we looked at some of these socks used for different sports. And Martina Navratilova wore these when she was playing tennis, and it reduced the pressure by 30%. And we showed that in diabetic patients, good socks, these were before smart technology, can reduce foot pressures. We showed that in a study, and can be helpful in protecting the foot. So again, each sock needs to be assessed carefully, and I think before we use anything, smart socks and any socks, they need to be validated by a proper study.
Thank you very much.
John, please.
Thank you. Do you think that hyperbaric oxygen and laser can improve the leg ulcer, or can help healing of the leg ulcer?
Well, if you want to waste money, you can use hyperbaric oxygen. I don't think hyperbaric oxygen has any use in the diabetic foot. And I spoke in a debate in the United States where I thought I'd be lynched because they're all worried about, because they get a lot of, you can claim a lot of money for hyperbaric oxygen. But the evidence is extremely weak. There were 4 randomized trials recently, 3 were negative. So I don't think hyperbaric oxygen has an effect. I think that, as I said, topical oxygen is showing promise. That might be much more helpful. But I would not use hyperbaric oxygen or laser. These all sound very sexy, but they're unproven.
The last question, please. Do you think it is better if the patient has ischemia due to arterial lesions to be corrected first before the temperature measurement?
Well, absolutely yes. I think our policy is if the patient has clear a neuroischemic or ischemic foot, we would certainly go to an arteriography, being careful with the contrast media and looking at renal function. And if there is a lesion suitable for angioplasty, we're doing distal angioplasty, even pedal loop angioplasties, and bypass surgery where indicated. There is a real place for bypass surgery and for angioplasty, and it's revolutionized the management of ischemic feet in diabetes, and I'm sure your co-chair would agree.
Okay, thank you.
Well, I hope he would.
Is there any questions? So thank you, Dr. Boulton, the president of the International Diabetes Federation, for this excellent talk. Thank you.